Hello everyone, I'm Deepak Shrivatsava. Today my topic is to discuss resistant hypertension and obstructive sleep apnea, a relationship between them, and can we avoid this threat and the complications related to these two disorders. I'm very happy to be here today speaking at the CardioCon 2022 and very grateful to the scientific committee chair, Dr. Kamal Sharma, as well as the members of the scientific committee. Let's start with the scope of the problem, what we are dealing with. The resistant hypertension certainly causes a lot of end organ damage, as this astute audience knows very well, and that relates with the cardiovascular disease, including the problems with the cardiac problems as well as the stroke. There are significant challenges when it comes to the management. They relate with the challenges with the medical management, but also the lifestyle management issues and the management of the end organ damage. The prevalence is really wide range depending on where we get the information from, somewhere between 2% to 40%, as you can see. But you remember the ALL-HAD trial, which was a few years ago, but had come up with some significant findings here that the hazard ratio with the resistant hypertension is pretty high when it comes to coronary artery disease, stroke, heart failure, end-stage kidney disease, and all-cause mortality. So there's almost twice as much risk of these complications when the patient has resistant hypertension or refractory hypertension, and we'll get into that in the next few slides. Increased rate of resistant hypertension and coronary artery disease and CKD compared to the general population. And this is common knowledge. There is nothing else that I'm adding new to it, except that what the ALL-HAD trial has shown many, many years ago, and we are still facing this same problem. The obstructive sleep apnea, and we'll learn a little bit about obstructive sleep apnea today, is definitely associated with essential hypertension as well as resistant hypertension. And then again, we really do not know exactly what the prevalence of this finding is. There was one study that showed that there is about 70% correlation between these two disorders. There are other studies which go as high as up to 85% or 90% of the cases with resistant hypertension will have obstructive sleep apnea. But when you compare it with the general population, it's about only 40%. So you can see the impact of resistant hypertension and how it correlates with the presence or absence of the obstructive sleep apnea will affect the end organ damage and at the end of the day, quality of the life. So patients have to be screened for the possibility of obstructive sleep apnea, which is relatively easier to do by way of interview, and then we'll talk about some of the screening tools. And then at the end of the day, you really have to do a test that will actually tell us whether they have obstructive sleep apnea or they do not have obstructive sleep apnea. And then treatment with CPAP is definitely very modest result with blood pressure change 4 millimeters of mercury systolic and 2 millimeters of mercury diastolic. But when you take a population, a subset of the patients who have the resistant hypertension, the effect seems to be a little larger. And we will examine that fact. What are some of the estimates here? So we really have to get to the bottom of the true resistant hypertension. So if you really look at it, it's about 10% of the treated hypertension population. So first of all, we look at the hypertension, what the prevalence of the hypertension, and then we start coning down to the point where we rule out the pseudo resistant hypertension and the secondary causes of the hypertension. And as you would notice that there are a number of secondary causes of hypertension. You know, the renal diseases, then some of the endocrine diseases, anatomical distortions, and then obstructive sleep apnea has been there for some time now as a significant cause a secondary cause of hypertension. So here's the definition of the resistant hypertension, but the key point here is they have to be on 3 or more antihypertensives. That includes different classes of drugs, including a diuretic. And then, of course, the causes of pseudo-resistant hypertension. You already know these. I don't have to read this slide. But more important thing is that this number here, that nearly 120 million people suffer with resistant hypertension across the world. So this infographic was very, very useful for me, and I do show it to my patients and colleagues when it comes to, and what it does to these 120 million people is increases their cardiac risk by threefold, which is a very, very high risk, as you would notice. It also impacts their quality of life significantly with mood, self-esteem, their personal life, and so on. So the impact is very, very high to a significant number of population around the world. So let's switch gear slightly and look at the prevalence of the obstructive sleep apnea. And the spectrum of the obstructive sleep apnea is pretty much that it starts with the snoring. And we all know that there is hardly anybody on the face of the earth who sometimes does not snore. You not necessarily have to snore every night, but there are certain things that happen. You are tired. Somebody had a drink of alcohol or using some pain medication, sedatives, and those nights you will have. Or you are sleeping on your back. So supine position, you snore more when you're sleeping on the side. But snoring is very interesting because it tells us that there is something wrong with the airway. I always tell the medical students that God has provided us with a trumpet to tell you that there is something wrong with the airway and you have to really examine it. But let's look at this slide here very, very quickly. This is the number of years here at the x-axis, and the y-axis at the percentage of prevalence of the snoring in this population. Then you can see they are both male and female, but as we continue to age, the appearance of the snoring, or the incidence of the snore, or prevalence of the snoring, I should say, continues to rise all the way towards the late middle life, I should say, and then there is a little dip, but then it picks up again. So overall, in this Italian study, 40% of the men and 28% of the women, which is much higher incidence than obstructive sleep apnea, snore. And this is a major sign that there is something wrong with the airway. Let's look at the OSA, why it is such a major issue. But if you look at this slide here, this is the age range here at the x-axis, and then percentage of claim lines from the insurance records to find out that people are getting a sleep consultation, getting a sleep study done, are being diagnosed with obstructive sleep apnea, and are treated for obstructive sleep apnea. And then these claims were paid by the insurance companies, and they were looked at as a surrogate marker for the prevalence of the obstructive sleep apnea. And you can see that middle age, right around when you are over the hill, 40 years or so, all the way to 70, you have the maximum number of people who suffer with obstructive sleep apnea, as much as 30% here, 20 here. So if you really look at it, almost 70% of the population during their lifetime here is at risk. Well, this is also your most productive time. You are working here, you're part of the workforce, and of course the sleep apnea is going to dampen your performance, will make you tired, non-restorative tiredness, and sleep which is unrefreshing can cause a lot of problems. This is also the age when you begin to have those diseases, the chronic diseases like hypertension or diabetes and others, which will cause a great deal of disability towards the older years. So this is a significant problem that we are facing, and we are facing it for now at least 3 to 4 decades. this cartoon was supposed to work, and this is supposed to have an open airway here with breathing in and out, and this is, as you can see, this is a closed airway during the inspiration, and here is the tongue, here is the vertebral column. So we are looking at the neck, here's the cerebellum of the brain, the spinal cord. So this is a dynamic MRI. For some reason the software didn't work. Apologize for that, but it proves the point that it can happen to anybody when they are asleep or taking a nap during the daytime. And it all relates to all these number of muscles here in our nasopharyngeal area, which are called the pharyngeal dilator muscles, and the most important being the genioglossus muscle or the tongue. Coincident with our inspiration, the muscle tone in the genioglossus and all these other muscles rises, and it prevents the collapse of the nasopharynx here because of the negative pressure that we generate in order to pull the air into the lungs. So this is where the problem is right now. We don't quite know that why in the population that suffers with obstructive sleep apnea, this system does not work, whether there is a quantitative or qualitative problem, but there is a disconnect between the inspiratory effort, negative pressure in the nasopharynx, and lack of increase or concomitant increase in the genioglossus muscle. People are looking at it. Someday we will find out an explanation for that. This is a simple slide which you know that hypertension is associated with impaired parasympathetic tone, so your system does not go down when you are trying to rest, and there is increased sympathetic activation. So there is nothing that you did not know, and it is responsible for the vascular remodeling, endothelial dysfunction, and of course the stiffness in the arterial system that causes the hypertensive state. Here in this cartoon, this is from Viren Sommer, one of our colleagues who many years ago actually studied the sympathetic nerve activity, as you can see here. And this is again, he is monitoring the EEG, EOG, the brain waves, the eye movements, EMG, and the person is happens to be in REM sleep here. They tend to have more episodes of obstructive sleep apnea, as the legend says here. You can see there is complete apnea, then some movement, and then here the airway opens and the person breathes. And during the obstructive sleep apnea event, you can see that there is a significant rise in the sympathetic nerve activity, and that is all over the body. And you can also see the increase in the blood pressure goes all the way up to about 200 in this particular slide, which of course it will be variable from one person to the other, some more, some less. But this is a very nice slide to really reflect on that what exactly happens. And if I had to show just one slide for this talk, I would have chosen this slide from the Tom Bradley, where he's showing that here is the obstructed airway. You can see the trachea, there is pharyngeal collapse, obstructive apnea, that means there is no air flowing for 10 seconds or longer, will resultant increase in CO2, which will normalize very soon as the airway opens. But more importantly, the PaO2, the oxygen, goes down. And oxygen goes down, which leads to a decrease in the myocardial oxygen supply. The chemoreceptors get stimulated. Again, the sympathetic nerve activity increases, causes the arousal of the person, which has its own set of problems with the sleep fragmentation and non-restorative sleep in the morning, because these episodes can happen up to 300, 400 times in a sleep period of 8 hours. But what also happens is that if you look at it, that this myocardial supply is happening because once the airway is closed, our defense mechanism is, what would you do if somebody is choking you? You try to breathe harder and you generate more negative pressure in your chest cavity, and that leads to increase in the transmural pressure in the left ventricle. And then of course your inspiratory pressure has to be very high in order to open the airway. That's exercise, and body wants to live. So brain snaps you out of the sleep. So maybe for an onlooker, eyes are closed, your behavior is that you are asleep, but in fact, the brain is awake. And that's where you have this continued sleep fragmentation night from night, which has both the physical, so cardiovascular, neurocognitive, and metabolic problems resulting from the sleep apnea. But here, if you look at it, if the transmural pressure is going to be high, your afterload is high, so you have a more myocardial oxygen demand. Now, in the setting of the more demand, now your supply is down, you can fill in the blanks. This group knows this better than I would ever know, that what happens subsequently, and which is listed on this slide here. Recently, pharmaceutics, a pharmacy general actually came out with this interesting graphic, and they have talked about everything that we already know, but they have put sleep apnea as a separate entity here for secondary hypertension, did not lump it, but also went ahead and talked about some of the screening tests, sleepiness scales and stop bank questionnaires, and in fact recommend polysomnography. So people are beginning to get a little more education about this, and this is becoming the part of the guidelines. So what do we do here? Here is the Epworth sleepiness scale. It's a very simple questionnaire, has 8 questions which ask you about your chances of falling asleep during certain activities, and you get a score here from 0 to 3, and then if you add up, 24 is the maximum you can get. Normal is sort of depending on how you look at the cutoff values, 0 to 7 or 0 to 10, but clearly 12 to 24 is highly abnormal. But the problem is that the sensitivity is just too low, the range is too wide, specificity, if anything, is modest, and accuracy is just a little over 50-50. So when this was validated against the PSG, but when it is validated against the home sleep test, then it does not change much. Sensitivity and specificity tend to remain in the similar range. So this is good as screening tool. You cannot make a prediction that somebody based on a score of the Epworth sleepiness scale is going to have sleep apnea. Recently, they came up with a new scale which is used, stop bank. So 8 letters here, 4 and 4 yes and no questions. So snoring, tiredness, observed sleep apnea or high blood pressure, yes or no, and then body weight, age, neck circumference, which is 16 inches for women and 17 inches for men, is considered predictive of sleep apnea, and if they are male or female. And then again, you add up these points. This stop bank questionnaire is also highly sensitive with false positive rate, obviously, and has low specificity. And then when it was validated against PSG and home sleep testing, this is again not any different. So very high sensitivity with high false positive rates and low specificity or modest specificity at the best. And the third common one is Berlin questionnaire, which is also as old as perhaps the Epworth sleepiness scale. It is little more granulated with 3 categories. So one is about the symptoms, snoring, how loud snoring is, how often you snore, etc. And then talks about the effect of the snoring, which is the tiredness, fatigue during the daytime, sleepiness, and so on. And then it gives one single question category, actually one single question for high blood pressure and the BMI. So if you're obese or not, so that is good category 3. And then you calculate these numbers. But looking at the sensitivity and specificity is still no different, despite the fact this also has so many variables that we screen for. So bottom line is, you screen the patients, and if they have high score, you subject them to a test. Some of the clinical evaluation findings, of course, I have no intention to go into details, but there are a few things that we can make a comment on, for example, nocturia. Well, many of these people have chronic diseases, already have end organ damage, already have diabetes, already have benign prostatic hypertrophy, which can cause nocturia. But because of the obstruction, and when the central blood volume increases as you generate more negative pressure in the chest cavity, and the blood gets sucked into the central circulation more, atrial stretch receptors, and of course the BNP is secreted, and that causes nocturia. And that's the physiologic mechanism behind obstructive sleep apnea related nocturia, both mechanical and chemical in that sense. And then, of course, this is common knowledge these days that everybody seems to hear somewhere or the other. These are the airways, type 4, type 1, sort of normal and completely closed. Everything in between is pretty much effort dependent. So either they have normal airway or abnormal airway. The typical test is very interesting. One of my medical students was kind enough to do this on herself. You can see that all these wires, and we will look at some of the snippets from the polysomnography. So there is nasal cannula, oral cannula. She has wires here with the EEG, around the eyes for EOG, the EMG, etc. These two belts, upper belt actually measures the movement of the chest with the inspiration, exhalation, and the belly. And they have to be in sync with each other. The paradox movement is that there is obstruction if the chest and abdominal wall are moving in paradoxical system. All these wires go into this head box, which is attached to the computer. And it's kind of a messy situation in real life. If you will see the pictures, it looks like very nice, tidy, but there are wires and everything. People wonder if they will be able to sleep in the sleep lab, but they do anyway. Here in this cartoon, you will notice that this is what we measure. So here is airflow, inhale, exhale, and then airway obstructs around here, and effort continues to increase with the chest and the abdomen, and then both these chest and belly, and normal breathing is like you are doing right now. When you inhale, your chest comes out and belly comes out because of the viscera gets pushed by the volume of the air filling up the chest. So they move in the same direction. But once the airflow is stopped and effort continues, there is this paradox that starts until the airway opens, awakening takes place, and then paradox ends. But coincident with all this, you will notice that the oxygen saturation, which was normal range, somewhere here begins to drop. The recording is a little bit delayed because we are measuring the pulse oximeter at the finger or the earlobe where the event is happening inside the chest in terms of the hypoxemia. So by the time blood travels, you see a little delay in the system. And there is something called hypopnea. And hypopnea is the reduction in the airflow by 30%. So it's not complete cessation of the airflow with continued effort with paradox, just like we saw in the last slide, and associated with certain amount of desaturation, 3% to 4%, depending on if you follow the Medicare rules or some other guideline. A typical polysomnography screenshot looks busy like this. It's not quite your familiar EKG tracing. Here is the electrooculogram. The EEG in this particular slide is only showing 2 channels, but now we are using 6 channels. EMG, EKG, so these are all electrical leads here. And then we have EMG on both legs, right and left, because these movements also help us figure out between the non-REM sleep and the REM sleep, but also a lot of movement disorders. And then snoring sounds, airflow we already talked about. Here again, obstructive sleep apnea is showing with the continued effort from the effort channels and oxygen saturation. So this gives us a very nice view of what is going on with the patient in supine position or side position or sometimes prone position, as well as what stage of the sleep. The computer allows us to do so many things. So here, this is quite a busy slide. You can see that there are a lot more EEG channels, EOGs here, like we saw in the last slide, and rest of the channels are here. So we measure about 22 channels in the real time, and there is a video recording that goes on, so we can correlate with patient behavior with what's happening with the rest of the body. So very comprehensive test. The good news is there are no needles involved, no IV lines, etc. So nothing invasive, and is a comfortable test for the patient. Again, as I said, the computer allows it to change the resolution and look closely. Here you can see, of your interest, that during the episode of the obstructive apnea, when the flow is stopped, you can see PVCs and bradycardia, as if, as a compensatory mechanism, the heart begins to slow down, but then the catecholamines are secreted because of that stress, and then they come around with the cardiac cycles, and here is increase in the heart rate. And this is again one of those problems that we have to deal with, and we see, and which has significant effect on the cardiovascular morbidity. And towards the end of the night here, we look at the entire night in one shot. So here's 4 a.m. and all those channels are now graphed very nicely. So you can see oxygen saturation. Here you can see the dip in oxygen saturation. And I'll make a chart for you. So here is all these wakefulness state and REM sleep, and during the REM sleep you can see a lot of apnea going on, and this purple color here is the hypopneas. So altogether they are causing a lot of arousal. So arousal by itself is a significant stress, in addition to the hypoxemia that is taking place here for the body. All right, so the treatment. The first line treatment for obstructive sleep apnea is continuous positive airway pressure. I'm sure you have heard. Sleep apnea activates a lot of intermediate mechanisms that you are well aware of, that becomes a substrate for the future cardiovascular disease. We already talked about the sympathetic hyperactivity. And until, I should say, 2016, the studies came out, the largest study, multi-center trial, multinational, came out of Australia, favorably known as the McCoy study, which showed that the CPAP does not do anything for the primary and secondary prevention of the cardiovascular disease. Well, we don't have time to talk about the, the good and bad side of this trial, but the bottom line was that the patients really did not use the CPAP for the required amount of time. So there is a controversy about the CPAP and the primary and secondary prevention. But when it comes to the blood pressure control and the modest effect of the blood pressure on CPAP, there is no controversy. This is well established. We'll go over a couple of trials very quickly in the interest of the time. Many of the observational studies and randomized control trials, they do show moderate positive effect, and a decrease could be very, very modest. A recent meta-analysis, towards the end of the talk, we'll go over this meta-analysis findings. Who responds more when they have resistant hypertension to CPAP? If they have younger age, they have a lot of oxygen desaturation, their blood pressure is not well controlled despite the effort, and then they are more susceptible to improvement. So there is a subset one can identify will be really benefited by the CPAP in this setting. I'm sure this is a 2013 trial, Hyperco trial, that you are familiar with, and again, this trial also showed that in excess of 70 to 80% people have sleep apnea if they have resistant hypertension. Then we will talk about, and they were set out to see whether the CPAP is going to help or not. It was open label randomized multicentral trial. 24 teaching hospitals, 194 patients, and they did the formal polysomnography in all those patients, and their sleep apnea was defined as the standard definition, apnea hypopnea index. That means every hour they have 15 events of either not breathing or not breathing enough with oxygen desaturation, and that means every 4th minute. But many of these patients actually will have more than 30 or 60 or 120 events per hour. They applied the CPAP for 12 weeks, compared with the control, and they found that there is a decrease in 24-hour mean diastolic blood pressure and nighttime blood pressure pattern. The trial was published in JAMA, and you can see here a change in the diastolic pressure, change in systolic pressure, and 24-hour mean blood pressure. Rather than going into numbers, and here's the CPAP use in the hours, and you can see the best line of fit right here. So about 4 hours into the CPAP use, you begin to see the discrimination, and this is consistent throughout the different times and blood pressure management. And the longer the person uses the CPAP, the size of the effect increases. So there is clear establishment of the intervention and the effect. So this is what this trial showed, and the mean change was not that high, modest, for somebody who is just not paying attention to the cardiovascular system as the cardiologists do. So you think about the microvascular physiology, you know that their heart is beating 80 times a minute, and how this translates into their cardiac work index when the heart has to continuously push against this pressure. So even a millimeter of pressure can translate into significant reduction in the cardiac work index. So that was the standard, really big, long trial that they had. And then came the RUSAS randomized control trial in 2018. It was randomized single-blind study, sham CPAP for 3 months, followed by active CPAP, the real CPAP for 6 months, and the controls were active CPAP for 6 months. And they compared between the groups, those who had resistant hypertension or with or without the obstructive sleep apnea. And they looked at some of the metabolic parameters, so leptin levels, and this has a science of its own, and some other metabolic parameters, and so on. Our interest was to look at the blood pressure, and they noticed that the active CPAP in these groups decreased nighttime blood pressure and heart rate in patients with obstructive sleep apnea. And there was no difference between CPAP and sham CPAP for the metabolic and sympathetic nerve, sympathetic system markers. So clearly, at least 2 trials over a span of 5 years were able to demonstrate the effect of the CPAP. I apologize for the busyness of this slide from the RUSAS trial, but the only thing that I would like to bring it to your attention is the nighttime blood pressure. Look at the degree of improvement, minus 6.3 here and minus 5.9. That's a significant improvement in the blood pressure. So after the Hypertension trial, multiple studies came out, and this is one of those very well done trials that people continue to study the results and the analysis of these trials for subsequent many years. And recently in Hypertension, Journal of Hypertension, editorial showed up, and they, of course, again validated the trial by saying this is the largest randomized control long-term longitudinal study, which has which showed the significant benefit of the CPAP treatment in resistant and the refractory hypertension. And then they said which subsets of the patients actually get benefited: people who use CPAP for the recommended period of time. If they had more severe sleep apnea, they will get the more benefit. If they have daytime and nighttime, the nighttime blood pressure gets affected a lot more, probably coincident with the increased parasympathetic tone. And people who had greater nocturnal desaturation, which will probably translate into worse form of obstructive sleep apnea. And then in more difficult to control form, so people are on different medications, lifestyle modification, and is still not able to get their blood pressure under control, they will probably be benefited by the CPAP therapy. So in this meta-analysis of 10 studies, they showed that the difference in the blood pressure reduction is between 4 to 5 millimeters of mercury, which is again a significant finding. They went over and analyzed it in many different ways. So the general population, 50% of the population probably has high blood pressure. If they are hypertensive, they have about evidence of general population evidence of, I want to say, obstructive sleep apnea in 40%, 30-40% patients. Same thing here. Resistant hypertension about 8% and refractory hypertension about 1% in general population. But with the OSA, 90% association between the OSA and refractory hypertension, 70% with resistant hypertension. Just hypertensive patients, they demonstrate the bilateral relationship here with the general population and the with and without the obstructive sleep apnea. And in normotensive people, that is the typical prevalence of the obstructive sleep apnea in general population. However, having said that, the CPAP effect, if you look at on 24-hour systolic and diastolic blood pressure, not much effect if they are normotensive, but as the blood pressure rises along these definitions here, you can see that the decrease in the blood pressure is more and more, all the way to the tune of 9 millimeters mercury and 7.3 centimeters, 3 millimeters of mercury in systolic and diastolic blood pressure. Now, do we have clinical evidence? Well, we reviewed these two trials, and it seems that there is a good signal, two good quality trials, but there is still room for improvement and many more trials to come. The cardiovascular risk of cerebrovascular accidents and coronary artery events also continues to improve with the CPAP use, depending on which category we are looking at. So clearly there is the maximum benefit somebody can draw out of these two categories. Having said that, the patient still has to make the lifestyle changes, and then at least in these two cases, resistant and refractory hypertension, the antihypertensive medications has to be concomitantly used, and CPAP is not the only answer to this problem. So here is this meta-analysis that we were talking about, and they looked at 10 randomized controlled trials, total of 606 subjects. And again, we'll just go over the highlights. 24-hour systolic pressure -5 reduction, then 24-hour diastolic -4.2 reduction, and nighttime systolic 4.1. So these are definitely the highlights. They were also looking at some of the other parameters and did not find any change. So we can summarize this that obstructive sleep apnea is a major secondary cause of resistant and refractory hypertension. We know that the epidemic or the pandemic of obstructive sleep apnea is rising because of the modern society lifestyle. We have a pandemic of obesity around the world. With that weight gain, obstructive sleep apnea is rising, and clearly it has significant impact on the prevalence of the resistant and refractory hypertension. They both contribute to morbidity and mortality, as we know. Basic screening can be easily done in the office, and the diagnostic and therapeutic resources definitely are available, sometimes not available in smaller communities, but definitely nearby larger communities and academic centers. You can find that. There are randomized controlled trials which have evidence for the benefit of the CPAP therapy, but more work needs to be done. Of course, we need the lifestyle modifications and supportive measures as well as the medications to continue. And most guidelines now have included the screening and assessment for the obstructive sleep apnea in patients who have uncontrolled hypertension. resistant hypertension and the refractory hypertension. With that, I would like to thank you again so much for listening to me patiently, and have a wonderful rest of the conference. Again, thank you so much, and I'll talk to you later. Bye.